Okay. So good morning, friends. Welcome back to Saturday Club of Baroda meeting. And today, a very interesting talk, bridging guidelines and practice, the hypertension therapeutic wheel. The very title suggests that there is always a gap between guidelines and what we practice. So we have Dr. Kiran Shah to enlighten us on this very interesting topic. Kiran Sai is a very, I would say, is a veteran member of Satellite of Baroda, not only as a regular attendee, but so many times I have heard him giving a talk on various subjects of his interest. And just to formally introduce him, he is a senior consultant physician practicing in Vadodara for more than 3 decades. He is director of Spandan Multi Speciality Hospital. He has several presentations at national and international conferences to his credit. He is fellow of Indian College of Physicians and also awarded fellowship of Diabetes India. So, with this brief introduction, I request Dr. Kiran Bhai to start his talk for about 40-45 minutes. We'll keep 10 minutes for discussion. Over to you, Kiran Bhai. Thank you.
Okay, so good morning everyone, respected senior Jagdish Bhai, Satish Bhai and all my senior colleagues. So we'll continue with the legacy of this Saturday Club. And as you already know, I have attended this time the Patna Epicon that was held in January. And rather than giving a brief overview of update of that Epicon, now I have selected this very interesting new topic which I have learned in Patna Epicon only. So I have decided to present this particular topic. You already know that there are so many guidelines. Just to say that there are almost 10 guidelines in Sydney city itself. Forget about the Australia. Forget about the rest of the world. But there are almost 10 guidelines for hypertension in Sydney city itself. Nearly 10 guidelines are already present in India also. And you know, there are so many guidelines across the globe. So how to bridge a gap between these particular guidelines and practice, that is what my interest. And this time, our Indian Association, that is Association of Physicians of India, have put forward Indian guidelines on hypertension 5, that is 2025, and based on that particular thing they develop certain tools as well as certain algorithms, and I am going to present one of the tools that they have already presented during this Patna Epicon 2025. So starting my topic today, this is the overall content or agenda of today's talk, that is global prevalence of hypertension, international high blood pressure guidelines, comparison of major hypertension guidelines, hypertension wheel, phenotypes in the wheel, prevalence of comorbidities and comorbidity itself in the India. So the global burden of hypertension, you already know there are nearly 140 crores adults between the age group of 30 to 79 years worldwide are suffering from having a hypertension. This represents nearly 33% of the population in this particular age group. So at least from 30 to 79 years of age group, nearly 30 to 40% of the population across the globe are suffering from hypertension. 2/3 of the adults with hypertension live in the low and middle income countries, that is LMICs that you already know. So we are harboring the major chunk of these particular hypertensive patients in our country, that is nearly 2/3 of the adult population. 600 million adults, that is 44% with hypertension, are unaware of their condition. That is the main thing which we have to keep in mind. Nearly 44% of the patients suffering from hypertension are unaware of their condition. And at least same population, that is 44%, are diagnosed and receiving treatment. But the thing is that only 23% have their hypertension under control. So 600 million patients are unaware of their condition. 630 million adult patients are receiving their treatment, but 320 million adults are only having their blood pressure under control. So we can say that hypertension is a major cause of premature death worldwide and is a global burden of hypertension. Hypertension is one of the #1 health related risk factors in India. Let us have something about This slide I have taken from the Ministry of Health from our website only, Government of India website. It contributes, just mark. It contributes to an estimated 1.6 million deaths annually in India due to ischemic heart disease and stroke. So hypertension is one of the most important cause of ischemic heart disease death and stroke death in India annually. It contributes to nearly 57% deaths related to stroke, and 24% of the deaths related to coronary heart disease are because of the hypertension itself. Between 20 to 40% Indians suffer from high blood pressure, and that is an average of 1 in 3 Indians. So we can say that every third Indian patient is suffering from the hypertension, or in this particular age group, that is above 18 years. Some of the alarming prevalence of the high blood pressures in India, that you can say that in Gujarat, Andhra Pradesh, Karnataka, Tamil Nadu, and Delhi, more than 55% of the adult populations are suffering from the hypertension. At the same time, there are a lot of comorbidities associated with the hypertension in India. As per this article, which was published in 2025, at the time of diagnosis, nearly 50% are having a diabetes, nearly 59% are having a stable IHD or coronary artery disease, 38% are having acute coronary syndrome, and remember that 87% of the people are having a chronic kidney disease as per the guidelines, as per these particular articles. So there are almost more than 50% of the patients of hypertension are suffering from some comorbidity at the time of diagnosis. Let's go further. That is the second part, that is international high blood pressure guidelines and comparison of the high major hypertension guidelines in brief 4-5 slides only. So you already know that the ACC-AHA guideline, that is for the blood pressure, you already know that in 2017, their target was 140 by 90 millimeter by G. And in 2025, now the target reaffirms that it is less than 130 by 80 millimeter. That is a drastic change. Instead of 140 by 90, now they recommend that it has to be less than 130 by 80. And remember that in 2017, everything in 2017 by ACC-AHA guideline, what was supported by the evidence from the sprint trial. And this sprint trial concept was that lower is better. Okay. But in 2025, everything has changed. Their concept is changed. That is, lower is better. Instead of that, the target has shifted from prevention. So they shift from pooled cohort equation to prevent equation. So now they believe that instead of lower is better, you should target the target organ damage prevention. That is the main concept. So there is a drastic change in paradigm shift also. In 2017, their pharmacological therapy was considered first-line therapy, that is thiazide, diuretic, long-acting dihydroxy AC inhibitors, and like that. And their important thing at that time was once daily dosing and single pin combination. Then there is a shifting. They now think that because of the hypertension, there is a cognitive functions affected, and dementia is one of the thing which usually complicated with the thing. So hypertension or high BP is linked to cognitive decline or dementia, and there is a strong recommendation because of that. There is, you have to maintain the blood pressure less than 130 millimeter of Hg. So new recommendation as per this 2025 ACC guideline is that blood pressure should be 130 to 139 or 18 to 89. That is, even if this blood pressure that is 130 to 190, that is elevated blood pressure, you have to give 3 to 6 months lifestyle changes. If uncontrolled, start pharmacotherapy at this particular level also. And you attain the target, that is less than 130 by 80 millimeter of hypertension. Even the new thing has already been incorporated in 2025 guideline, that is the resistant hypertension. And updated guidelines on renal denervation therapy has already been included in these latest guidelines. So in 2025 hypertension guideline of ACC, there are 5 major important things that it prevent. Calculator is already available. It is a personalized decision making, easily available. Earlier treatment to protect heart and brain, that is main recommendation. expanded screening, that you try to detect it early and monitor it early, that is kidney disease and primary aldosterone also. Updated medicine that is included is GLP-1 receptor agonist in obesity. Pregnancy and postpartum care is redefined. And renal denervation now an option in resistant hypertension. So a big step towards more precise, preventive and patient-centered hypertension management. Even in ESC, that is European Society of Cardiology approach, is also more or less similar to this particular ACC or AHA guideline. They also target the adult blood pressure that is up to 120 to 129 millimeter of G. What is main important in this particular ESC guideline, that BP monitoring should prefer out of office BP recording. That is the main important thing in ESC. So they always prefer that instead of office BP, that is recording of blood pressure in office, they prefer that out of office BP has to be there at least diagnosed at the time of diagnosis of hypertension. And manual BP is only validated on if there is a atrial fibrillation. In this particular thing, they also put a stress on management also, that is lifestyle changes for 3 months, even if it is the blood pressure is 130 to 139. If uncontrolled, start the medication, and they applied risk-based approaches, more focus on the high-risk patient. So that is what their new recommendation in ESC. Comparing our hypertension guidelines, India and international, that is major clinical practice guidelines in India and abroad. That in non-hypertension in 2017, it was clearly that it should be less than 120 by 80, and elevated blood pressure was 120 to 129 and less than 80. In 2020, Indian guidelines on hypertension also stress put that it says optimal pressure means less than 120, 80, normal means less than 130 and 85, and high normal means 130 to 139 or 85. And hypertension, they had also defined in 2020 guidelines of Indian hypertension. It is almost same as that of rest of the world. So grade 1, grade 2 and grade 3, that is what we already know. Now further going ahead with this, that is what is hypertension will. Okay, our main topic. So we also need to update, okay, growing, because of the growing prevalence of hypertension and its associated comorbid necessitates a unified approach to management rather than giving a different guidelines and different numbering or title. It has to be a unified approach for the management of hypertension. Though hypertension is a modifiable risk factor, you already know that its management is complicated by diverse phenotypes and associated comorbidities that we had already seen, that at the time of diagnosis only we are facing so many associated comorbid. And not only that, there are so many phenotypes, diverse type of blood pressure also we nowadays already know. Over and above, these comorbidities often remain undiagnosed at the time of diagnosis. So if you go into the remote places, or even if in cities or like urban areas also, you record the blood pressure and it is only 140, 150, then it is recorded. But rest of the thing we usually don't take into the consideration. That is the main front. Like associated obesity, associated tachycardia, we have to think in terms of this particular thing also. So all these things we have to keep in mind while the diagnosis of hypertension. So if we start treatment based solely
em test chọn cái này nha từ mau nhau
hello. Okay, so if we start treatment based solely on blood pressure level, that is one size fits all approach to hypertension is inappropriate and it is inadequate also. So that is the main thing which you have to look into the matter. So in 2025, Indian guidelines on hypertension has proposed, and all dignitaries and faculties across the India, that is Dr. Girish Mathur, Jyotirmay Pal, Dr. Wonder, and all these dignitaries are the part of this steering committee, and they formulated the Indian guidelines on hypertension, that is fifth guideline after 2019, that last guideline. So what is new in Indian guidelines on hypertension 5, that is 2025? The latest issue of this Indian guidelines on hypertension that is grade fifth guideline, presents a comprehensive update for the 2025. These revisions addresses critical gaps and advancement in hypertension management. It also reflects the latest research and clinical practices specifically for the Indian population. So this is the main important thing in 2025, our Indian guidelines on hypertension 5. So it is a comprehensive update. It's addresses critical gaps and advancement in the hypertension management, and also reflect the latest research and clinical practice specifically for the Indian population. We will see in details. But the thing is that these guidelines are almost like a book, almost 100 to 150 pages in each and every guideline. So Dr. Gurpreet Wonder and Dr. Kamlesh Tiwari and others, after a comprehensive review of national and international hypertension guidelines, published a review article, review consensus statement in JAPI in 2025. That is the thing what they have published. A multidisciplinary specialty or multidisciplinary consensus on individualized treatment strategies for hypertension phenotypes and comorbidity. This is the very important article which they have published in 2025 JAPI. That has already been mentioned here. So my entire topic today's talk is based on this particular article, which is the consensus statement. Rather, it provides a very good algorithms and tools, handy, easily available. So that is the main thing. And that's why rather going into the deep guidelines, and you can have some handy, which you can stick on your table or in your chamber, and you have easily idea how to go ahead with the patients of hypertension and its management. And one of the most important thing that it has incorporated patient-centered approach. They had included the various phenotypes and comorbidities also. So that is the main important things in this particular consensus, multi-specialty consensus. This expert panel comprises cardiologists, nephrologists, endocrinologists, primary care physicians, and all the specialties which are necessary for the management of the hypertension. They address key issues like diagnostic challenges, phenotype-specific strategies, and holistic management approaches. Also look into the limitations of existing practice and to identify areas requiring concessions. In these particular guidelines or consensus statement, they also identified different phenotypes, identified blood pressure control algorithm or were also put forward. A step care approach for the combination therapy also suggested. We'll have 1 or 2 slides only for this blood pressure control algorithm and step care approach, because ultimately I am going to discuss the hypertension wheel also. That is one of the important tools. So they also propose a handy tool like India's first therapeutic wheel for the management of hypertension associated comorbidities and phenotypes. So let us have a first detail how they propose a management of the hypertension algorithm. They says that if you are having the age less than 40 years, then every 3 yearly you supposed to have a screening for the hypertension. If your age is more than 40, every yearly you have to have a hypertension screening. Second thing, confirming hypertension, you supposed to have self blood pressure monitoring, pressure measurement and ambulatory blood pressure management, or repeated standard office blood pressure recording. So they here put stress on self blood pressure monitoring, that is home blood pressure monitoring, ambulatory blood pressure monitoring, or repeated standard office blood pressure monitoring. So all these three are looking at our country's condition. And they also applied a patient-centered care. That is, if the blood pressure is optimal or normal blood pressure that is less than 130 or 85, then there is only lifestyle measures, screen BP every opportunity, and HBPM or ABPM is preferred in such condition. But if your blood pressure is recorded high normal blood pressure, that is 130 or 139, then or 80 to 85, then what they suggested that if your age is more than 85 years, then there is no need to go for very detailing. if there is associated age is more than 85, or if you are having a moderate to severe frailty, or if you are having a symptomatic orthostatic hypotension, or the short lifespan is expected, then there is no need to go into the detail. Just lifestyle monitor, screen BP every opportunity, ABPM or HBPM is preferred. But if you are having a established CVD, moderate to severe CKD, hypertension mediated organ damage, diabetes mellitus, or familiar hypercholesterolemia, then yes, you have to have a regular checking. If your risk factor is more than 3, then you have to go everything in detail. That is what they have suggested. Now, if you have already recorded hypertension, that is systolic blood pressure more than 140 and diastolic blood pressure more than 90 at the time of diagnosis only, and your age is less than 40, then the resistant hypertension and has to be evaluated. And suggestive of signs and symptoms has to be screened in detail at the time of diagnosis only. So at that time, you screen for secondary hypertension, target secondary hypertension effectively. At that time, if you don't have any secondary hypertension causes, then lifestyle measures, pharmacotherapy, and monitor BP and medication tolerance. But if you are having a secondary causes, then you have to treat, or if you are in a resistant hypertension, then you have to treat it very effectively. And at that time, they have also suggested the step care approach also. So here also they had put forward the ABPM, HBPM preferred over the office blood pressure. So they have put a stress on out of office blood pressure measurement. But you know that there is no possibility in our India to have each and every patient to have out of office pressure measurement. So handy apparatus at the home is not possible in our country. Another important thing is that they have suggested 6-step approach for the combination therapy in hypertension. So step 1, if you are having a low risk high normal blood pressure, that is 130 or 139, and that is a low risk high normal blood pressure, there is severe frailty, elderly, or orthostatic hypotension, then that is a step, and in that particular patient you are supposed to give only monotherapy. So in step 1, the monotherapy is suggested only for those who are having a low high risk normal blood pressure, frailty, elderly patients, or orthostatic hypertension. Otherwise, from very beginning, they suggest that low dose dual combination therapy that is suggested in these particular guidelines only. So rather than monotherapy, now that low dose dual combination therapy is the rule in at the start of the treatment. After 2 weeks, your blood pressure is not controlled, and if you need, there is a compelling indication, then that is a step 2, increase the triple dose, low dose triple therapy. That is what they have suggested. Okay, A, B, C, D, that we will go into the already everything. That is, A is for ARBs, AC inhibitors, B is for beta blockers, C is for calcium channel blockers, and D is for the diuretic therapy. In step 3, maximum tolerated dose of triple therapy is to be given. And in step 4, you try to screen after that for the resistant hypertension. In that step 4, MRA, that is the mineraloreceptor antagonist, that is spironolactone, is to be added. If side effects, then use the epinephrine. So with while using spironolactone, you develop something side effects like gynecomastia or that hyperkalemia, then use the epinephrine. Now in step 5, they add alpha blockers, centrally acting agents, or direct vasoactors like arcamine, or what we know that is clonidine, or alpha blockers agents in step 5. And in step 6, they also suggested that renal denervation is the treatment, or it's an option for the step 6. So in first step, low dose dual combination therapy. Second step, a low dose triple combination therapy. Third step, highest maximum tolerated triple combination therapy. In step 4, 4 drugs combination therapy that include the MRA. In step 5, 5 drugs can be given, that is alpha blockers, or centrally acting can also be given. And even if that is not, a sixth approach or sixth option is the renal denervation. So with this step care approach and combination therapy, they also introduce certain algorithms and certain tools also, and they introduced the India's first hypertension therapeutic wheel. That is what they have proposed. And this is the first hypertension wheel of India that is proposed. You can see that it is very well picturized. Color coding is also good. This central is the monotherapy, or at the time of diagnosis, consider monotherapy, how to avoid in frailty patient or like that. So they have given a good color coding also. This light or gray simple color, that is first line. For the second line, that they had given blue color, light blue color. In the third line, that is the this Chamli, what exactly? And in the red color, they have contraindication, and the outside that they have mentioned the phenotype of the person. So they have incorporated first line, second line, third line, contraindication of certain drugs also included, and in the outside that there is a phenotypes are also included. So that is the main important thing of this particular wheel. We'll go into the detail of each segment in step by step. So this is the first therapeutic wheel. You can stick this particular therapeutic wheel picture in your office chamber, and you will have at a glance everything available. Simple. So what are the phenotypes in the wheel, or what phenotypes they have identified in these Indian guidelines? We'll go step by step everything. The controlled hypertension, masked hypertension, wild caught hypertension, sustained uncontrolled hypertension, nocturnal hypertension, isolated systolic hypertension, isolated diastolic hypertension. So nearly 8 phenotypes they have identified, and each are having their description, each are having their definition, each having their prognosis, and management is different. That you already know. Those controlled hypertension means normal office and out of office BP every time, or those patients who are having a treatment on treatment and their blood pressure is controlled. In that case, management, you already know that there is a antihypertensive and lifestyle modification. And if your blood pressure is very well controlled, then there is a lower risk versus uncontrolled hypertension. Second thing, masked hypertension. Masked hypertension means that the patient is having a normal office blood pressure. Means if the patient goes to the office and if you record the blood pressure, doctor records the blood pressure in the office, then the blood pressure is normal. But at home or outside moving, that the blood pressure remains elevated. So they have included this particular phenotype also in this particular. And you must remember that the prognostic is also important, that there is increased CV events and organ damage if you are having a masked hypertension. White coat hypertension, the risk is more than the normotension, but it is less than the sustained hypertension. So you have to identify each every phenotype at the time of diagnosis of this hypertension. White coat hypertension means if the person is going to the office, then looking at the doctor only white coat, they have a hypertension, and that is known as the hypertension. But at the same time, their blood pressure at the home is normal, or out of that office, the blood pressure remains normal. So they give importance to this also. Then sustained hypertension, that is every time your blood pressure is out of office or in office, that blood pressure remains high. Then there is increased CVD, stroke and mortality. Nocturnal hypertension, that is another important phenotype they have identified in this particular guideline, that the systolic blood, sleep blood pressure or blood pressure at the time of sleeping, if it is more than 120/70, or if your blood pressure doesn't dip more than 10% while sleeping, then you consider that it is having a nocturnal hypertension. And this nocturnal hypertension has increased severity and organ damage also. And in that particular also, there are different things which we have to consider. Isolated systolic hypertension, that is more than systolic blood pressure more than 140 and diastolic blood pressure less than 90, and it is very common in elderly population. If you are having isolated systolic hypertension, there are increased chances of the stroke and severe risk. The isolated diastolic hypertension, that is the blood pressure systolic is less than 140, but diastolic blood pressure is more than 90, and that is very commonly we found in person with the cervical spondylosis. It is very common in a young age. and it may progress to hypertension. That is what we have to keep in mind. So what do these Indian guidelines define phenotypes? That is white coat hypertension, that is high office BP but normal home BP. Mask hypertension, that is incidence is about 5 to 10%, that is normal office BP but high home BP. Sustained hypertension means everywhere the blood pressure, whether it is office BP or home BP, high blood pressure. And true normalization means office BP as well as home BP are normal. So they have clearly defined in these particular guidelines that these are the phenotypes. Now coming to the comorbidities. We have already seen that the phenotypes already been decided, described in this particular hypertension wheel as well as hypertension guidelines of our Indian origin. They have also identified the comorbidities. So if you already know that in previous slide also that hypertension at the time of diagnosis is associated with very comorbidities like CKD, coronary, that is chronic kidney disease, coronary artery disease, heart failure, dyslipidemia, obesity, stroke, tachycardia, and diabetes. So these all are the comorbidities which are associated with the hypertension at the time of diagnosis only. And we have seen in previous slide that is that in India, as per this article that was published in 2005, almost 50% of the hypertensive patient at the time of diagnosis are having a diagnosis. There 59% are having a stable coronary artery disease or ischemic heart disease. 38% are having acute coronary syndromes like thing, and CKD is almost associated in 87% of the patient at the time of diagnosis of hypertension. So this is a very important thing which has been already highlighted in these particular guidelines and tools. So there is a need for a comprehensive tool for the treating hypertension that has to be based on phenotypes and comorbid, and it should be handy. So management is complicated by diverse phenotypes such as mask hypertension, nocturnal hypertension that we have already seen. So one size fits all approach of hypertension is inadequate and inappropriate. That is very clear. The frequent coexistence of comorbidities like diabetes, dyslipidemia, and obesity at the time of diagnosis also. So the hypertension management must adopt patient-centered approach at the time of diagnosis, at the time of management. So these comorbidities often remain undiagnosed, delaying effective intervention also. So in this particular therapeutic wheel for the management of hypertension associated comorbid, they have already incorporated everything. So this is India's first therapeutic wheel for the hypertension management, outlining the first line, second line, and contraindicated antihypertensive medications for each comorbidities. So at that time, they had also given certain different terminology. Like if you are having a hypertension and kidney disease associated, they label it as a nephrotension. If your blood pressure is hypertension and vascular disease or heart failure or coronary artery disease, then they label it as vasotension or CAD tension. If you are having a lipid abnormality at the time with the hypertension, then it is known as the lipotension. If you are having obesity, then it is known as the obetension. If you are having a stroke or some neurology associated abnormalities or comorbidities at the time of with the hypertension, that is neurotension. If you are having a tachycardia, which is also now considered as the major risk factor, isolated risk factor for the hypertension and its complication, then it is known as the tachytension. If you are having a diabetes associated, then it is known as the diatension. So this diatension, nephrotension, vasotension, CAD tension, lipotension, obetension, neurotension, and tachytension, they have put forward in this particular wheel to have very good impressive image in our mind. So coming to the details of this hypertension and phenotypes and comorbidities in this particular. So we have seen this particular wheel and how this different segment of this part of this hypertension wheel, and go into the detail of this particular wheel, each comorbidities or each phenotypes. First, hypertension and diabetes. That is what you have seen, that it is a hypertension and diabetes. They have also mentioned that it is a first line, second line, third line contraindication. Okay, so let us have some saline features of this particular pattern. You already know that hypertension will approaches to hypertension and type 2 diabetes. Hypertension and type 2 diabetes commonly coexist, that you already know. Hypertension patients often have insulin resistance. That is also very important thing. High risk developing diabetes in hypertensive patients. So there are higher risk of developing diabetes in hypertensive individuals. And the treatment goal, very important, is that the primary objective of the treatment of hypertension and diabetes is to achieve a target BP control. And early detection and aggressive management are the most important crucial point in this particular management. That is when the diabetes and hypertension are coexisting. So they have find out that the first line is the ACE inhibitors or ARB plus calcium channel blocker. If the blood pressure is not in target, then second line, that is ACE inhibitors, ARB plus thiazide diuretics. So this is the algorithm which has already been outlined in this hypertension. This is the second line, that is ACE inhibitors, ARB plus thiazide diuretics. And even if the blood pressure is not controlled in diabetic patients with hypertension, the third line, that is ACE inhibitor, thiazide diuretic, or calcium channel blocker plus spironolactone, that has already been added. So what this will and what this guideline of Indian hypertension comparable with the global guideline, how it is differs, or what are the lacunae in this particular, that we also see in this particular thing. The global approach to management of the patients with hypertension and type 2 diabetes. You already know that ADA in 2024 incorporated and says that the blood pressure in such type or such situation should be less than 130 and 80 millimeter per G. And they also recommend that ACE inhibitors or ARB as a first line hypertension, but they mentioned that ACE or ARB if albuminuria is already present, and substituted one if not tolerated. Second thing, what this International Society of Hypertension incorporated SGLT2 inhibitors recommended for CV and renal protection. SGLT2 inhibitors for cardiac and renal bed, which, whereas in our Indian guideline, this SGLT2 inhibitor at this point it is not mentioned. So that is the drawback. They also prefer RSSDI, the ARBs or ACE inhibitors. And they in European Society of Hypertension also included Finerenone, but our guideline has not incorporated. So there are some differences in this hypertension wheel or this hypertension algorithm which has been took into the consideration while upgrading this particular hypertension wheel. So the wheel shows ACE inhibitors or ARB calcium channel blocker diet as a first line without stratifying whether the albuminuria is present or not, or CKD status in diabetes patient with hypertension. The guidelines allows more flexibility. That is recommended monotherapy initially prefer ARBs, and many include SGLT2 inhibitors and albuminuria based selection. So this is a difference between wheel and international guidelines. Okay, so these are the drawback of this particular wheel, that there is no further stratification in diabetes mellitus. Second important segment, that is hypertension and chronic kidney disease, that you already seen that hypertension and chronic kidney disease is a part of the wheel. The management of hypertension and chronic diseases, basically here it depends on the CKD stage, whether it is CKD stage 1 to 3 or whether it is CKD stage 4 or 5. You already know that CKD stage 1 to 3 means eGFR is less more than 30 ml per minute per 1.76 meter square, and eGFR if it is less than 30, then it is considered as stage 4 or 5 without dialysis. They have step 1 and step 2. So what this wheel says, there is a management of patients with hypertension and CKD. The important saline features is that there is a growing burden, that CKD and end-stage kidney diseases are increasing, mainly due to rising type 2 diabetes mellitus, hypertension, and there is a bidirectional relationship between the hypertension and causes of the kidney disease CKD. that hypertension worsens the kidney disease and CKD worsens the hypertension. So in diabetic patient, hypertension accelerates decline in the renal function, and the management basically depends on the stage of CKD, presence of albuminuria on AGFR level, that has already been mentioned in this particular wheel and algorithm, that is your stage 1 to 3, then ARB, ASE inhibitors or plus calcium channel PET is a combination therapy as step 1. Or if you are not on dialysis but stage 4 or 5, then ARB, ACE inhibitors plus calcium channel blocker or loop diabetes. As step 1, they prefer thiazide diuretic, and as step 2, they prefer, in step 1, in 4 and 5 stage, they prefer loop diuretics. Then in further step 2 or as a second line guideline, they prefer that add spironolactone with. You have to keep in mind the caution that it produces potassium or beta blocker or upper blocker or central agents. So this is very well clearly highlighted in this particular thing. So guidelines comparison, if we compare with the international guidelines, that it is very well delineated. If the International Society of Hypertension guidelines incorporate AC SGLT2 inhibitor if the eGFR is more than 20, and they also incorporated finerenone in type 2 diabetes with the CKD. Whereas in this wheel, the traditional CKD stages, that is already incorporated, but they lack the stratification and newer therapies. Whereas the guideline offers albuminuria diabetes stratification and includes SGLT2 inhibitor. So the clinical implication of this is that wheel is a handy for reference, but it needs updation guidelines needed for the CKD specific targets, outcomes and safety. Third point, that is hypertension and coronary artery disease. So we already know that where at the time of diagnosis, only the hypertension and is associated with the coronary artery disease. That is the important segment. And in that particular thing, they recommend that it should be below 130/80 mm per Hg, but should not be below 120/70 mm per Hg. So the lower the better concept here, they already not highlighted. What is the approach to patients with hypertension and coronary artery disease? Hypertension is a major risk factor for the coronary artery disease that you already know. It accelerates coronary atherosclerosis and causes narrowing of the coronary arteries. And if the blood pressure, systolic blood pressure is elevated, then it produces the myocardial ischemia, cardiac hypertrophy, myocardial fibrosis, and requires aggressive blood pressure and cardiac risk management. So in first line management of the hypertension in coronary disease, propose that the beta blocker should be incorporated as a first line therapy along with AC inhibitors and ARB. Second line or second option is the AC inhibitors, ARB plus beta blockers or calcium channel blockers or calcium channel blockers plus diuretic. And third line, if first is not used, any of the two, that is ABCD. So comparison with the global guideline, yes, it is as far as the compatible with the global guideline. In ESH guideline also, they included beta blockers and dihydropyridine group as for angina. So they further stratified that if there is angina, the beta blocker is the or dihydropyridine group of calcium channel blocker is the first line choice. And here is in ESH or International Society of Hypertension, which is also the same if needed. So wheel shows the class level options but lacks context of the history, that is angina. So in international guidelines, they recommend that if this angina is present, then the beta blocker, whereas in wheel, it is the first line. So further context or upgradation of this wheel is required. It should be in the context of the history, that is angina, heart rate targets, long-term therapy and consideration. And which does not guide the patient-specific factors like angina or thing in as far as this coronary artery disease or hypertension association is concerned. The hypertension and heart failure, that is one of the most important thing or that we had already seen in the hypertension associated with the comorbidities. They had also included the research work of this EMPIREC trial, CANVAS trial, paradigm shift. This EMPIREC guideline and CANVAS trial already suggested the SGLT2 inhibitors, because the SGLT2 inhibitors, there is risk reduction of 38% for death and 35% risk reduction from hospitalization for heart failure. Paradigm trial put for more stress on the valsartan sacubitril superior than ACE inhibitors in preventing hospitalization and death. So that has already been incorporated in this particular will. So what are the important saline feature as far as the hypertension heart failure is concerned? There is associated with the heart failure across all left ventricular ejection fraction level, there whether it is reduced ejection fraction, moderately reduced ejection fraction, or preserved ejection fraction, particularly important for Framingham study says that there is a 91% of the heart failure patients had prior heart pattern, and consensus trial says that enalapril reduced 1 year mortality by 31%. Other effective therapies in heart failure is that there is ARNI, eplerenone, finerenone, or loop diuretic. So in hypertension associated heart failure management, heart failure with preserved ejection fraction first line therapy is the ARNI rather than ACE inhibitors, beta blockers, SGLT2. That all you know that they are the important pillars and they have already been incorporated. In second line, they have included thiazide or thiazide-like diuretics. Here also they have included everything. So it is almost compatible with the international guidelines and everything has been incorporated. Okay. So another important segment, that is hypertension and dyslipidemia. You already know certain important thing as far as the hypertension and dyslipidemia is concerned. Both are major cardiovascular risk factors. They are frequently coexist, share common pathophysiology like obesity, insulin resistance, cytokine dysregulation, chronic inflammation, and up to 40% newly diagnosed hypertensive patients have more than one lipid abnormality. That is one of the most important thing. And management should consider effect of antihypertensive drugs on lipid profile and overall CV risk reduction strategy. So whenever there is a hypertension and dyslipidemia, first line is the ACE inhibitors or ARB and calcium channel blockers. Then second line, add if someone has not used. But one of the important thing which we have to keep in mind, you can add the low dose thiazide diuretics if you have not controlled the blood pressure. But because the thing is that this thiazide group of diuretics or any diuretic that produces the lipid abnormalities, so we have to closely monitor. At the same time, beta blockers are also to be given, but you have to give the cardioselective beta blockers, or you can use the direct vasodilators. Then one of the most important thing, that hypertension and obesity. Here is also they have delineated very important thing. GLP-1 receptor agonist, that is the already you can see that semaglutide and tirzepatide can reduce the blood pressure. It has already been included in international guideline, and it has already been mentioned in these Indian guidelines also. What are the things about the hypertension and obesity? The management of hypertension and obesity, it depends on the presence or absence of metabolic syndrome or associated diabetes, kidney disease, or CV disease. So you have to look for the metabolic syndrome, CKD, or CV disease when you are diagnosed having obesity and hypertension. Lifestyle therapy is the first line for all in such situation. Weight reduction, 5 to 10% weight reduction significantly lowers the blood pressure. Calorie restriction is also suggested. Reduce salt intake. Physical activity of at least 150 millimeters per week of moderate intensity has also been suggested in these guidelines. Mediterranean diet or DASH diet, and expected BP reduction with weight loss is about 1 millimeter Hg per weight loss. That is what. So if you are in a hypertension and obesity, then the first line is thiazide diuretic in our Indian guidelines, calcium channel blocker, or ACE inhibitors. And if you are having hypertension associated with the metabolic syndrome, then the first line is ACE inhibitors or ARB. If the blood pressure is not achieved, then the second line, that is ACE inhibitors, ARB plus calcium channel blockers or alpha blockers. And here also they suggested that you can use the low dose thiazide. So antihypertensive drugs consideration in obesity, what the American guidelines or international guidelines suggest that ACE inhibitors or ARB are the preferred choice because the RAS is activated in such type of situation, and dihydropyridine group of calcium channel blockers is can also be given because they are metabolically neutral. So in first line hypertensive, antihypertensive. If you are having a hypertension and obesity, then ACE inhibitors or calcium channel blockers. Use with caution, that is thiazide diuretics or beta blockers, because they produces weight gain, worsening the glucose or lipids and insulin resistance. So pharmacotherapy for weight loss, that is what a newer approaches, that is semaglutide and tirzepatide, can also help in weight reduction with the hypertension, and that is why that has been included in the international guidelines. So thiazide use, the will recommends first line, while the guideline advises caution obesity due to the metabolic effects. Whereas GLP-1 agonist and other emerging therapies promising for the dual weight and BP benefits should be considered as an adjunct. Class, that is hypertension and stroke, that is a very important statement. In that they have included the considered the progress trial, because you already know that progress trial is one of the trial where they have considered the combination of perindopril and indapamide, as because it produces 43% risk reduction of the stroke. So hypertension and stroke, saline features the primary prevention, that BP reduction is more important than specific drug class. So overall, it is effective driven by the BP lowering. The preferred classes are ACE inhibitors, ARBs, or thiazide-like diuretics, and calcium. And if there is a secondary stroke prevention, then ACE inhibitors, thiazide-like diuretic combination is prevented, that is perindopril and indapamide. ARBs in secondary prevention, that is telmisartan and as per this. So as per these guidelines and therapeutic management of hypertension post-stroke or history of stroke, first line ARB, something like that. Second line ARB, ACE inhibitor, calcium channel blocker, and third line thiazide diuretic. So this enhanced based oral therapy in IV agents are not included in our therapeutic world, but yes, these are very much well incorporated in the international guidelines. So we have to incorporate these also into the therapeutic our will. So we have to keep in mind. Last part, that is the hypertension and tachycardia. You already know that tachycardia is one of the important isolated risk factor for the hypertension and its complication. So if you are having a resting heart rate more than 90, yes, you have to give the first line beta blocker, second line ACE inhibitors or beta blocker or calcium channel blocker, third line ACE inhibitors, beta blockers, or dihydropyridine group of calcium channel and one of the most important thing is that do not give beta blockers and dihydropyridine calcium channel, because they both produces severe bradycardia. So this has to be taken into the care while managing the hypertension and tachycardia. So there are certain important things which has been highlighted about the beta blockers and nifedipine. That beta blockers in hypertension with tachycardia, if it is a drug-induced tachycardia, then the metoprolol is preferred, and nifedipine should be avoided in tachycardia, that is 2025 AHA as per the guideline, because it produces the tachycardia itself. So another important segment, that is hypertension and pulmonary disorder, though it is not incorporated in this therapeutic wheel, but it has already been mentioned in the guidelines, in our Indian guidelines, that is first line agent in pulmonary disorder is associated, then the calcium channel blockers and beta blockers can be avoided. Okay, so in COPD, asthma, and OSA, first line is calcium channel blocker, first line is calcium channel blocker. But if it is OSA, then the beta blockers and calcium channel blocker can be used with cautions. So at the end of this, in Patna, what our elect president of API, Dr. Jyotirmoy Pal, told us that this hypertension wheel is the first of its kind therapeutic wheel for the Indian patients. This multi-specialty consensus underscores the critical importance of tailoring hypertension management to individual patient profiles, considering specific BP phenotypes and associated comorbidities. BP integrating comprehensive BP monitoring with the personalized therapeutic strategies, that healthcare providers can enhance treatment efficacy and improve patients' outcome. This approach not only addresses the unique characteristics of each patient, but also aligns with the principles of precision medicine, ensuring that interventions are both targeted and effective. But what is my take-home message at this take-home is that hypertension will integrate first line, second line drug choices, contraindication, and lifestyle intervention at a very handy tool, comprehensive but complex. But it provides a good to use in the busy clinical practice. Some comorbidities should be incorporated in that thing, and rare phenotypes are not included in this particular wheel. It provides a simplified layout, and using color coding provides a good usability also. But what I suggest that digital interactive interaction can enhance in clinical implication. Regular update is needed even in this wheel also. And inclusion of out of office BP monitoring in wheel has to be mentioned in specific in the center. So overall, the wheel bridges the evidence and personalization, but careful guideline integration maximizes the clinical utility. That is what I can say, and my take-home message at the end of this particular talk. Thank you for your patience hearing. I think I am in time. Okay.
You are in time. Very exhaustive and elaborate, review of the guidelines. Thank you very
But
much.
sir, if you put that particular wheel on the table, yes, it gives a very simple.
Good.
Okay.
And very proud that India has come up with this kind of
Yes.
guideline. So now the house is open for comments, questions. We have a few minutes. Dr. Rakesh, can you just unmute your mic?
Hi, that was excellent, Kiran. Simplified such
Rakesh.
a complex topic.
Oh, yes. So basically,
Yes.
it has incorporated all these phenotypes and comorbidities at glance only. So that is the main important of this hypertensive wheel, that therapeutic wheel.
Yes.
Yes.
Learn something.
Yeah.
Thank you.
Jagdish bhai, you have a question.
Yeah.
Yes.
Kiran bhai, they have not mentioned about diurnal variation. Sometimes blood pressure, which you record in morning, afternoon, evening, and efficacy of a medicine lasts for certain time.
Yes.
After that effect is gone, blood pressure has tendency to rise again.
Yes.
So drug therapy should include low dose continuous drug therapy.
Yeah, sir, for that they have already find out the phenotypes, that is masked hypertension or like this. In masked hypertension, it remains normal in office, but at home it is like that. In nocturnal hypertension or non-deeper, they find that there is a hypertension during the night also, but during daytime also it is not there. So in that particular segment, they have not mentioned anything in the will, but yes, the guideline is already incorporate that thing, and algorithm clearly says that yes, you should take into consideration this thing also.
So what is the rationale for not having monotherapy and always dual therapy, whatever the stage of hypertension?
Sir, like that, you already know that diabetes and hypertension, diabetes, multiple pathophysiological cell octet. You already know that there are octet. That what octet exactly known, defrozen octet. There are multiple pathophysiology. So same way in hypertension also there is a multiple pathophysiology. So if you will give only one class of drug, then each and every pathophysiological aspect will not be incorporated. Plus, if you will step care approach, like if you give one therapy, one class of drug and increase that dose to a maximum, then the side effects of that particular drug is also more. So it is now recommended that if you want to address a hypertension which are having a multiple pathophysiological aspect, you should not give only one class of drugs, but you should give combination, so that it will address more pathophysiological aspect and they have a synergistic effect. At the same time, there will be a side effect associated with the higher dose of these particular drugs of a single class, then also can be avoided.
But problem with these newer guidelines, like they are lowering the limits for defining hypertension. So don't you find it difficult to tailor the treatment, because we say 135, 140 and say 80, 85 hypertension. Some have only systolic and diastolic may not be so high. In that case, how do you actually adjust the doses? Is it not very difficult to use two drugs and then tailor them? how long does it take for the patient to stabilize on 2 medications?
So very scientifically recommended dose has to be fixed dose combination therapy. Otherwise, like whatever in India is happening, 5 milligram, 2.5 milligram, and combination with 10 and other thing, then it will really create a chaos. But if scientifically proven fixed dose combination, if you use, then it will be a good. Otherwise, it is going to create a definitely chaos.
I hope all physicians keep updated with these newer guidelines so there is less chaos. So if there are no comments, I think we end the session here. Thank you very much, Kiran Bhai, and thank you all
Yes.
for joining. So we
And
meet
thank
next
you
Saturday.
everyone for joining and listening peacefully.
Thank you.
But
Thank you.
I feel that such a type of application of sticker-like thing in chamber gives a very good idea to the physician in our busy schedule. That is
Great.
main idea of this.
Thank you. We meet next Saturday again. We have
Yes.
some 4 Saturdays lined up. So
Yeah.
we'll be meeting next Saturday again. Thank you. Thank you.
Okay.